Good evening, everybody. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to be talking about vitiligo from a patient journey perspective. Our moderator this evening is Dr. Leon Kircik, who is the president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, Indiana University Medical Center in Indianapolis, Medical Director of Physician Skincare, DermResearch, and Skin Sciences in Louisville, Kentucky. Our guest speaker this evening is Dr. Pearl Grimes, who is the Director of the Vitiligo and Pigmentation Institute of Southern California, Clinical Professor of the Division of Dermatology at David Geffen School of Medicine, University of California in Los Angeles, California. Please remember that this activity is jointly provided by Medical Education Resources and the International Dermatology Education Foundation. This activity is supported by an educational grant from Insight Dermatology. So we'd like to thank our supporter, Insight Dermatology, for making this educational event possible. A couple of logistic tips before we begin. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you'd like to ask a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. You must fill in the survey to receive your CME credits. A certificate will be issued upon completion of an evaluation survey, and the credits must be claimed by May 15th, 2023. Again, if you want to submit questions, please submit them in the right-hand side in the question chat pane, and I wrote a little note in there, or I typed a little note in there so that you would see where to type in your questions. So this activity has been designed to meet the educational needs of dermatology healthcare professionals involved in the care of patients with vitiligo. There is a knowledge gap among healthcare providers on how to treat vitiligo among their patient population. In support of improving patient care, this activity has been planned and implemented by MER and International Dermatology Education Foundation. MER is jointly accredited by the Accreditation Council of Continuing Medical Education, the Accreditation Council of Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education to healthcare teams. The disclosure of conflicts of interest are displayed here. And the content and views presented in this educational activity are those of the authors and do not necessarily reflect those of MER or IDEF or Insight Dermatology. The authors have disclosed if there is any discussion of published and or investigational uses of agents that are not indicated by the FDA in their presentations. Before prescribing any medicine, primary references and full prescribing information should be consulted. Any procedures, medications, or other courses of diagnosis or treatment discussed or suggested in this activity should not be used by clinicians without evaluation of their patient's condition and possible contraindications on dangers in use, review of any applicable manufacturer's product information, and comparison with recommendations of other authorities. The information presented in this activity is not meant to serve as a guideline for patient management. Again, a certificate will be issued upon completion of an evaluation survey. Credits must be claimed by May 15th. This link will be emailed to you within 1 to 2 days of the webinar, and if you have any questions, you can contact MER at the phone number displayed on the screen or jsykes@cmepartners.com. So without further ado, I will pass the floor virtually to Dr. Leon Kircik.
Thank you, Roxanne, and good evening, everyone. Thank you for joining us to another series of International Dermatology Education Foundation educational program. So tonight, we are very lucky to have Dr. Pearl Grimes, who's a very good friend of mine, but also I call her the queen of the pigmentary disorders, who's gonna discuss vitiligo, new treatments for vitiligo, but most importantly, patient journey with one of her patients. Before we go any further, I'd like to tell you a little bit about my foundation, International Dermatology Education Foundation. Next slide, please, Roxanne. So IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. We have been all over the world with virtually, especially lately during the pandemic. We have programs, next slide please, Roxanne. We had programs not only in the US and Canada, but also in South America, in Southeast Asia, as well as Europe and Middle East. So as you can see, those are a couple of our previous educational sessions where we have discussed multiple various topics in dermatology. Next slide, please. So tonight, as I mentioned, again, we're very lucky to have Dr. Pearl Grimes, who's gonna give us her patient's journey through vitiligo diagnosis, as well as different treatment options. And actually, her patient is here live, and we will hear directly, and we're gonna have a great discussion. Again, thank you for joining us. And Pearl, please take it from here.
Leon, it is such an honor for me to join you this evening for this discussion regarding an exciting time for investigators and clinicians who have dedicated their lives to patients with vitiligo. And it's also a special moment for me to literally sit with one of my vitiligo patients as he is willing to share his personal story. Well, and I'm going to call it our story because I've been his caregiver. So I hope our audience enjoys the next 45 to 50 minutes. So I think we have a polling question. So I'm going to read the question. What drug is FDA approved for repigmentation of vitiligo lesions? Is it tofacitinib? Is it tacrolimus? Ruxolitinib? Is it ANC? Or all of the above? This is for our attendees. Please submit your responses. So these are the responses. Tofacitinib, 9%. Tacrolimus, 10%. Ruxolitinib, 35%. ANC, 28%. All of the above, 18%. So let's tease out the answer. So the only FDA-approved drug that we have for repigmentation of vitiligo is ruxolitinib, 1.5%. The brand name is Opzelura. And we're going to talk a little bit more about that. And, you know, we're open for, you know, I was involved in the phase 2 and the phase 3 trials to bring Opzelura to the marketplace. So we have enormous experience in using it. So hopefully there'll be a number of questions. So these are my disclosures. I have no conflicts tonight in being a part of this session other than having spent the majority of my professional career being involved in clinical and basic science aspects of vitiligo research. So I think a great place to start this evening is to really just highlight some of the issues regarding the burden of disease for patients with vitiligo. You know, vitiligo, if you look at diseases in the house of dermatology, I think that the psychological devastation of vitiligo is enormous. Patients experience self-esteem issues, self-worth issues, isolation, stigmatization, and recent studies suggest that there is an increase in anxiety disorders, depressive disorders. So for everyone listening, I think one of the key take-home messages tonight is that you really understand the trauma induced by the contrast between normally pigmented skin and white patches. This condition affects all racial ethnic groups. It has an equal incidence. Sometimes we forget about how common it is in our skin types 1 through 3. You know, the only differences are if you're an individual with skin of color, the condition is much, much more obvious. But all our data suggests that the incidence is equal. And we're going to hear from my patient this evening, Neil. And I've been following him since 2019, and I'm not going to tell his story. He's going to tell his story. And when he came at baseline, you can see the significant depigmentation on his face. And I will tell you, this is what I will tell you. He came in with angst and lacking hope. And I think he will share that journey with you. And this is where he is today. He literally has virtually 98 to 99% repigmentation of the areas of the face that devastated him when he became my patient in 2019. So certainly from a therapeutic perspective, if we look historically, our key therapies have been topical corticosteroids, the calcineurin inhibitors. For those patients who have more extensive involvement, narrowband UVB phototherapy. We rely on the excimer laser for more limited lesions when we need light treatment. Autologous grafting procedures are amazing for patients who have stable, limited disease. But I think this is such an exciting time for vitiligo, for patients and researchers, because the playing field is changing rapidly. And as mentioned earlier, I think that the great thing that I'm so excited about is the fact that we today have the first FDA approved drug for topical agent for repigmentation of vitiligo. And it is a JAK inhibitor. It inhibits JAK1 and 2. It's a JAK1 and 2 inhibitor. And that is ruxolitinib, brand name Opzelura. Neil will, at some point during the lecture, share his journey using Opzelura. And you'll get a sense of multiple therapies that we tried. So again, multiple new therapies in the pipeline: afamelanotide, which is a synthetic analog of alpha MSH, the prostaglandin F2 alpha analogs. I use these as second-line treatments: bimatoprost, latanoprost. We'll see more new biologics for vitiligo. So again, I think this is really an exciting time. So with that, Leon, I'm going to turn it back over to you, and I think you have some questions for Neil.
Oh yeah. Let's see if I can come on here. Can you guys see me?
Yes.
Yes, you can. And you can hear me. Okay. Neil, first of all, welcome. I really appreciate you being here, giving the time to our audience. I think it's a valuable, very valuable experience for us to hear as providers, as caretakers about your experience, and I am sure we have a lot to learn. So first is, if you don't mind, I think, unfortunately, I hear all the time, some of us as from the dermatology community, some from the third-party payers, you know, it's not a big deal, it's vitiligo, nobody dies from it, right? Can you tell us a little bit how it impacts your life physically, but most importantly, really emotionally, feeling-wise, the stigmatization? Tell us as much as you can so that we can all hear it as derm community about your experience and learn.
Okay, I'm very happy to be here, and thank you for inviting me. Well, when I first heard the word vitiligo, when my dermatologist of many years said that that might be the problem, and she called in 2 of her colleagues, and they looked at me, and one of the colleagues said, "Neil," she put her hand on my hand, "I think you have vitiligo." When I heard the word vitiligo, like many, I thought of Michael Jackson. or the model that has the vitiligo, somebody that looks spotted like a leopard and for which there was no, quote, cure. I went to see 4 different dermatologists to try to find something to help me. 4 different dermatologists. And I was dismissed by some of them as, well, it's not so bad. You're light skinned. You don't go in the sun. It's not so visible. But I saw it. Every time I looked in the mirror, I saw all the areas that were depigmented and worrying, is this going to get worse? Now, I'll admit, I'm a vain person. I'm in the entertainment industry. I do a lot of socializing. Once or twice I get my picture taken, and I like to present the best possible appearance. I always believe when you look good, you feel good. When you feel good, good things happen to you. So I went to these 4 different dermatologists. Nobody offered me a real treatment plan. Nobody took my blood work or talked about the autoimmune component of vitiligo so that I could understand what was happening to my body rather than it being some kind of curse that just happens to people. And I was even advised against having some of the therapies that Dr. Grimes has used for me and were successful. I was advised against it because they told me, well, you might get a little pigmentation there and it's going to be spotted and you're going to look worse. So when I came to Dr. Grimes, she gave me hope, and I actually broke down in tears because it was getting me anxious and depressed. I was on Wikipedia. I was on everything you shouldn't look at to try to find out about vitiligo and all of the witchcraft components you could mix together to put on your face to try to fix it. And so she gave me some hope, and she said to me on our first visit, I can help you. I believe I can repigment you. And I had a sigh of relief, and I felt, well, there is now a light at the end of the tunnel, and however long it takes and however many visits it takes, and luckily I have good insurance, which maybe some people don't have, and that's unfortunate. And I stuck with it, and now, as Dr. Grimes said, I'm near 100% repigmented, and this is something I just don't have to worry about when I look in the mirror. I just have to worry about other things.
That's so good to hear. But from what I heard from your story, I think there are a couple of things I'd like to emphasize and maybe sort of rediscover. One is, from what I heard, you've seen 4 other dermatologists, all good doctors, but most likely probably lack of the treatment options maybe. And at the time, there was not an FDA approved treatment for vitiligo. Mostly you were discouraged by basically lack of cure or treatment. Did I hear you correctly?
That is correct. I was told to not try the light treatment. One doctor did not have the UVB, they only had the UVA. And I was basically told, well, we could try this, you could try this, but it's probably not going to work, and your case isn't so bad.
So Pearl, if you can interject here and tell us, you as a vitiligo expert, how do you handle these different treatment options, especially the fact that when we did not have an FDA approved treatment, how do you present it to the patients and how do you handle it?
Well, Leon, I'm not being arrogant, but I tell my patients, if I can't repigment your face, I take it personally because historically, our yield has been so high in being able to repigment the face and the neck. You know, keep in mind, I was the one who reported the first publication in using tacrolimus for vitiligo. So the pigment, the majority of pigment that Neil achieved, we did it prior to Opzelura's approval. But I'm going to tell you the beauty of how Opzelura factored into his story. So we used tacrolimus, we used topical steroids, we used a rotational algorithm, we used phototherapy, and then ultimately we used the laser. And so those are the modalities that gave us the degree of substantial repigmentation that he achieved. So when Opzelura was FDA approved, we decided, well, wow, there's some areas that we need to finish. And so I switched him over to Opzelura, and he continued. That repigmentation kicked in again. And that's really one of the beauties of what we're seeing with this new agent, is I have so many patients now on Opzelura who had plateaued with our standard therapies, and then you initiate therapy with Opzelura, and it puts them in that exponential phase of repigmentation again, which is just really exciting for me.
Yeah. So great. Thanks, Pearl. The second point, Neil, if I caught it correctly, again, please correct me if I'm wrong or if I misunderstood. Most of the doctors who sort of said, you know, it's not a big deal, especially for you as a light colored person, it's not going to impact you as much. Is that correct?
That's correct. You can't see it so badly. You're a man. Don't be so vain. That's what I got. And one of the 4 doctors I sort of forgot. She had the laser, but only wanted to treat one spot because she didn't have confidence. And again, she was afraid that I was just going to get speckles of pigment and that it would be worse. And I searched out to get Dr. Grimes, and I hope I'm not embarrassing you, but it's true. One of the reasons I came to Dr. Grimes because she has a practice that's called the Vitiligo Institute. And I knew that this practice was dedicated for that specific autoimmune malady, and that she would have access to the latest information and research. One of my dermatologists said, I have to admit, Neil, we're not experts in this office about that.
Yeah. So Pearl, if you don't mind commenting a little bit on what happened to Neil between the light color skin patients, darker color skin patients, and how the disease impacts them. Do you think it impacts them equally, socially, psychologically, emotionally, or what do you see?
So Leon, I'm so happy you asked that question, because I think there is this myth that remains that vitiligo is more common in darker skinned individuals. Number one, all the data suggests that it is not more common. It has an equal incidence. You simply see it more. Now, having said that, I want to share my experiences in running this institute for over 25 years as I transitioned from full-time teaching. The majority of my patients here are skin types 1, 2, 3 for whatever reason. These individuals come in and they are distraught over their vitiligo. So the take-home message is this. While studies suggest that the burden of disease may be greater in darker skinned individuals, however, the burden of disease is significant in all patients who have vitiligo. Regardless of skin type. So we can never make the assumption that because you have lighter skin, okay, because it may not be as visible, you're not traumatized by the condition. So it is an autoimmune disease. There are multiple comorbidities. And one of the great fears I find for all patients, even if they're limited, it's, oh my God, is it going to spread? What's going to happen? So again, I don't want the audience to trivialize vitiligo in lighter skin. The burden, every patient feels the burden of this condition.
Unfortunately, that is so true. Neil, tell us a little bit. You told us a little bit in the beginning how you felt, lack of the faith, lack of the treatment options. How do you feel now after the treatment that you're repigmented? When you look in the mirror, and going back those couple of years ago, how does it compare? How do you feel?
Well, when I looked at the photos that they showed at the beginning of the webinar, I was a little taken aback because I now had forgotten how bad it really is. And when you look under the Woods lamp, which no dermatologist had done prior to Dr. Grimes, I see how dramatic the results are. So it's almost like, wow, that was so long ago. I don't even remember how bad it was, and I just feel good that I'm here. And now when I come here for my treatments, I just feel it's just sort of part of my routine in my life now, like working out and putting on the topical. It's just sort of like part of my skincare. But you know, I'm just so happy that it's not something I think about as much or very much when I look in the mirror, you know, when I'm shaving or primping, that, oh my God, is this worse today? Is, you know, any piece of lint, I think, is another new spot. So that is off of my plate, and I just feel much better about myself. I've had other health issues that have been more serious, and yet I don't think I felt as bad about that as the vitiligo, because those other issues, I knew there was a quote cure.
So I think we heard about your emotional journey. Tell us a little bit, and I heard you use the word Woods light, that Dr. Grimes was the only person who looked at you with the Woods light. Tell us a little bit about your medical journey, in the fact that, did you have any problems with the treatment options, right? Did you have any side effects? How was it?
No, I really had no side effects. I mean, a little bit of erythema at the beginning when I wasn't used, you know, my skin was not used to light, because I'm a person who's taken care of my skin, and I've stayed out of the sun for decades and have religiously used a high SPF physical sunscreen. So when I was exposed, you know, to the light in the beginning, I was a little red, and maybe almost a blister, and that was fine. Dr. Grimes, you know, took care of that, and no side effects from the topicals. And you know, I've been very happy, and I started seeing results from the moment I saw a result. The moment I saw the first spot of repigmentation, I had hope, and that's why I just kept going, because it got better and better. And I think once you have a treatment plan and the disease is taken seriously, and I learned that it is an autoimmune disease, and then I looked back into my family history and found we do have autoimmune in my family. We're from Eastern Europe, and it's not uncommon, and that had never been addressed. So again, I just, you know, just feel so much better, and I'm in this participating in this because I want to let other people know. In fact, if I see a stranger on the street, I said, excuse me, I see your pigmentation, and I think you may have what I have, and I have a doctor you could see.
Thank you for those comments, actually, and thank you for being here. Pearl, can I ask you a little bit, for those of us maybe need some hearing from you about the Woods light, and how do you use the Woods light? And just tell us a little bit. You know, it's sort of, I remember the Woods light from my residency days, but for the new graduates, for the new kids on the block, tell us a little bit the use of the Woods light. I think it's gonna be very important for those of us who see vitiligo patients.
You know, the Woods light is so key in being able to visualize the extent of vitiligo in lighter complexion individuals. And I will tell you, nowadays, I use the Woods light in all of my patients. I simply don't limit it to my patients with fairer skin. But if you do have a lighter skin patient, you know, we turn the lights off, we use it, and everything, you know, everything then becomes visible. You know, we will even do photos with the lights out, just to be able to capture those lesions. When we do facial photography, there is the ultraviolet mode that allows us to capture it. So I think it has a place in all patients, but I think it is just 100% essential when you are evaluating individuals of lighter skin tones in being able to visualize the extent of vitiligo, because I will tell you, it's not uncommon, Leon, for patients to come in and they'll say, oh, Dr. Grimes, I think I just have this spot here. That's all I can see. Are you sure? Oh, yeah. No, I'm good. It's like,
Yeah.
you're here. So one part of what we do is every patient who has vitiligo gets a full body exam so that when we are done, I know the extent of involvement. So
Yeah.
our protocol, detailed history, full exam with the Woods light, everyone gets baseline labs as well. And this has been our protocol for years and years and years.
Tell us, what labs do you get?
Our standard labs are, we get a CBC with the DIF, sedimentation rate, metabolic panel. I do thyroid, TSH, free T4, thyroid antibodies, because the most common associated autoimmune disease in vitiligo is thyroid disorders, in particular Hashimoto's thyroiditis. I also routinely do an ANA. 30% of patients who have vitiligo will have a positive ANA, while lupus is one of the, I see lupus with vitiligo, but it's one of the less frequent associations. If your patient has normal thyroid function tests and they have a thyroid antibody, then no doubt that patient is at an increased risk of getting thyroid disease. Whereas the ANA, in our experience, and we've been looking at this since the 80s, the ANA really is more of a marker of autoimmunity. There may be some correlation with vitamin D levels. We're looking at this, and I do a vitamin D level too, because vitamin D is such a key player in autoimmunity. And so I think that healthy vitamin D levels are key for a healthy functioning immune response. And there's a great study that came out of the Brigham on 25,000 patients. And they showed that there was a correlation between vitamin D deficiency, autoimmune disease, and you decrease the frequency with healthy vitamin D levels.
Great. Now, Neil, I heard you a couple of times saying autoimmune disease, right? Why do you use that term instead of using almost vitiligo? And how do you think it's so relevant, what the term you use, for especially third-party payers, the insurances, that they don't want to pay for treatment of vitiligo, and they call it, it's a skin disease, it's a cosmetic disease, not a big whoop?
Because autoimmune is the cause. And there are many autoimmune diseases that get more attention, and you see commercials for all of the drugs now a lot on television. And vitiligo, it sounds like, oh, I have a rash, I have poison ivy, you have dry skin. And now knowing that there was a cause, this is a legitimate thing. I didn't do it to myself. I didn't do it because I used the wrong products on my skin. Which you can do. For me, it makes me feel legitimatized, and this thing, it's a real thing. If you tell somebody I have vitiligo, they say, "What's that?" And then you tell them, "Oh yeah, I think I have a spot here myself on my leg." It's not a big deal, and that's not true.
So the next question I wanted to ask, which I almost forgot, but I want to go back and visit. You did mention Michael Jackson, right? And the pigmentation, the depigmentation of, his disease, which at the time we didn't have much options anyway. So Pearl, how do you come, and do you still use the depigmentation method, or who do you think it's a good candidate?
Excuse me, I still, Leon, depigment patients. And this is my criteria for depigmentation. If I have a patient who has, let's say, 40% vitiligo, and they have used, they've used narrowband UVB. They've had, they've been consistent, and you've tried light in combination with topicals, no response. There's some patients where if they don't respond to narrowband, I've even resorted to going back to PUVA. So you've tried everything, nothing works. They have extensive disease, and the patient says, oh my God, I don't want light anymore. Can you please consider taking the color out? And my response is, okay, let's walk you through the benefits and the risk. And very often for that patient, they're ready to just rest and take the remainder of the pigment out. I will tell you, Leon, when the patient arrives at that place, I have never depigmented a patient who was unhappy. Now, there's another group of patients whose vitiligo progresses rapidly. They have 50% depigmentation or 75% depigmentation, and they present to us and they have no desire. They have very extensive disease, and they have no desire to undergo the rigors of repigmentation therapy. That's the other group of patients that I will depigment.
Now, I started looking at our question panel. There are some questions. It's actually pretty appropriate to both of you guys. That it says, ruxolitinib, when we look at the primary endpoint and the clinical studies, we see 6 months, right? The primary endpoint is 6 months, unlike other conditions that we are used to in dermatology, atopic derm, psoriasis, where we start seeing results at 4 weeks, 8 weeks, 12 weeks. So this is a long the way. 6 months is a pretty long time. How do you handle that, both mentally, emotionally? The patients prepare them that, you know what, this is gonna take a long time, because it's almost like the trees that are burned in the forest, and now we have to regrow those trees to become mature trees to see that pigment. How do you handle that?
Great question. This is how I handle it. First of all, let's address the clinical trial. In the clinical trial, we could only use ruxolitinib. So that is monotherapy data. Let us now talk about what is going to happen in real world experience. As you know, if you look at all of the monotherapy treatments, it does take time to repigment vitiligo. However, as I mentioned earlier, the face and the neck are easier to repigment. So I think what we're going to see down the road is how are we going to speed it up? So I will tell you how I think we're going to speed it up. Dermatologists, we are such creative people. I'm sorry.
Yeah.
We just love to mix and match and figure it out. So, and I think that this work has already started. I think we're already doing Opzelura and phototherapy. That's going to speed it up. Okay, we're using Opzelura and topical steroids. So we'll do Opzelura and the excimer laser. So those studies will come. And I think what you are going to see is, so the data was 6-month data, but if you look at the photos, patients were kicking in much sooner. So for vitiligo patients who have been told, oh my God, nothing works, if they see, Leon, that something is happening, and I think Neil can attest to this, if you come and see me in 4 or 8 weeks and you see that you're beginning to get color when you started with hopelessness, that gives you hope to continue the journey.
I agree. I just want to add one thing, because
please,
if you want to build up your muscle, or if you want to lose 50 pounds, that's going to take effort and that's going to take time. But once you start seeing some results, you stick with it because you get You get greedy. You want more results. You get 50%, then you want 75%. Oh, maybe I can just get to 80 or 90. Then 90 is not good enough. I want to go all the way to the finish line. But I want to say something about the laser and going back to what we talked about before, that vitiligo is not just a cosmetic condition. We're in Beverly Hills. Almost all of the dermatologists are giving you some cosmetic options for injectables, et cetera, and lasers. And there are dermatology offices, and it says the dermatological office of so-and-so and the cosmetic laser center. So as a consumer, as a patient, when you hear the word laser, you think about something that's going to tighten your skin, make you look younger, and that ever-present word, brighten your skin. They're not saying anything about restoring pigment. So everything with the word laser seems to be associated with cosmetic. And laser is a therapeutic tool. And none of my other dermatologists had the excimer laser. So laser is something that is therapeutic. It's not just cosmetic, and vitiligo is not a cosmetic condition.
I agree with you 100% wholeheartedly.
And you know, Leon, I think that this is so important because I think in our space as clinicians, caregivers, we still have work to do amongst our colleagues in dispelling the myth that vitiligo clearly is not a cosmetic condition. There was a recent paper that I just quoted. It was a survey done amongst, I think, maybe British dermatologists, but it was out of Europe. And of the physicians surveyed, I could not believe the number who considered vitiligo a cosmetic disease.
Yeah.
And that is heartbreaking in 2023.
So what can we do, Pearl, to disseminate the message among our colleagues? Number one, about that it's a medical problem, it's an autoimmune problem. Number two, we have new treatment options, and we should stop being hopeless, which unfortunately makes our patients hopeless and despair.
You know, we're in a great place right now, and that is we have the first FDA approved drug. And I do think that Insight is committed to physician education and patient education. And so I think we have a TV ad now. We have, social media programs. I think that it is about education, having vitiligo on CME programs. And I think that hopefully in the next 3 years, if we took a survey today and we repeat it down the road, I'm hoping that if we did a polling, the number of physicians who would respond, it would be less than 10% who would respond that this is a cosmetic condition. And you know what? I'm optimistic. I think it will happen. I think it will happen.
Yeah. I have some questions, and those are really appropriate questions, especially for you, Pearl, for someone in this field. What are some other new topical treatments in the pipeline?
You're going to see other topical JAK inhibitors in the pipeline. There are a number of drugs in the pipeline that impact the immune pathway beyond the JAK-STAT pathway. Those drugs are in early development. But as I said, I think most of the drugs will impact the aberrant immune response at some point.
How about
I'm hoping that we get afamelanotide approved. And I'm a cheerleader for afamelanotide, and I will tell you why. When you look at drugs that impact the aberrant immune response, this is how I view it. We're putting out the fire. Okay, we're literally You know, it's no longer burning, but we still have to plant new soil. We have to put new trees in. So
Yep.
how do we do that? We have to stimulate those remaining melanocytes in the outer root sheet of the hair follicle. This is where alpha melanotide comes in. And my guess is there may be new agents in the pipeline as well to expedite melanocyte degeneration. So for me, that's the path forward. We're putting out the fire and we're planting new trees. And that's how we're going to speed it up. And moreover, we're going to look at there's a whole new area of science in really teasing out those melanocyte reservoirs even beyond the hair follicle. And so that's the ultimate path forward.
How about any oral treatments in the pipeline, Pearl?
We're going to look at, you know, well, certainly from the biologic realm, okay, there's heat shock protein, Caroline LaPoule's group, John Harris's group. They're looking at IL-15 or pathways that block memory T cells. Okay, there's work on T regulatory cells. So if we look at cytokines, what's up and down regulated, I think that, you know, innovative scientists will look at multiple pathways that we can up or down regulate that ultimately will help us distinguish the fire.
So I have one question. It says, do you ever use oral JAKs off-label for vitiligo? If so, how has the response been?
You know, I have used oral JAKs for vitiligo. It's not my favorite, only because I'm one of those people who I don't necessarily want to keep a patient on an oral JAK long term. So my ideal approach would be a topical agent. I'm such a big proponent of phototherapy. While the oral JAKs do work, and I know that they will be approved, I think the idea, and I know, yeah, and we've used them, I just don't use them extensively. I think I would want to use them like I use steroids to help with stabilization, early repigmentation, and then I'd want to transition that patient to something easier. For me, it's always about the risk-benefit profile.
Yeah,
It's
of course.
every day, risk-benefit, risk-benefit, risk-benefit.
So having talked about risk and benefits, one appropriate question is, how long do we keep the patients on ruxolitinib? Well, at least and then safety versus efficacy. I know that efficacy-wise, looking at the studies, right, on the open label study, the patients almost doubled their efficacy results when they were on this ruxolitinib for a whole year, which was very impressive. I thought, you know, you see doubling the efficacy of the results. But in your experience, what do you see?
You know, and we did we were involved in the phase 2 and the phase 3 trials. I think that the way I will situate ruxolitinib in the real world, I'm probably going to use it in a rotational algorithm. I'm not going to abandon my old tools. Absolutely not. You know, there was a great paper on tacrolimus in the JID journal. Tacrolimus works. Topical steroids work. So I'm going to take my old tools and I'm going to combine them with my new tools, and I'm going to combine them with my second line tools. I love the prostaglandin F2 alpha analogs. They work. So the beauty for me is I have something new. So it's kind of like how I manage melasma. I'm constantly rotating so that you don't acclimate, You don't develop a tachyphylaxis to one thing. And so that is the beauty of having these additional tools. You don't have to rely on one agent.
Excellent. Neil, I just heard the word melasma, and we have so many different treatment options for hyperpigmentation and melasma, but not much for hypopigmentation, for vitiligo, right? What do you think on that?
Well, that's interesting that you brought that up, because for several years, the dermatologists I saw thought I had melasma. And that was because they were looking at the normal pigment against the light pigment and thinking that the normal pigment was melasma. So I can't tell you how many AHA peels I had and VIP peels and all of that, which may have exacerbated my condition. But again, even the ads in the cosmetic magazines and the fashion magazines are talking about OTC serums that help brighten your skin. Nothing is telling you about if you have hypopigmentation. In fact, every summer in a fashion magazine or a general market magazine, it'll tell you summer's coming, use the sunscreen, and here's pictures of skin cancer, and you can measure it, and if the spot changes, go to your doctor. I've never read one thing about hypopigmentation, autoimmune vitiligo. I've not read one thing. I have read articles about, oh, I have vitiligo, I'm embracing it. That's fine if a supermodel wants to go out there and embrace that. But I hope that that does not discourage people who don't want to embrace that from getting treatment. Because when you say you embrace it, I think you're indicating, well, it's hopeless, so I'm just going to learn to live with it. But again, it's not hopeless. And I wish there was more education, because if some general interest magazines or television talk shows would talk about this, it would encourage people to go see their dermatologist, because they might have this.
I really think that's such a good point. Lately, it's been quite fashionable to embrace problems, right? It's giving up, and instead of fighting this, embracing problems. It's quite interesting that you brought that up. Pearl, do people come to you embracing their vitiligo?
Well, usually the people who come to see me want to have their vitiligo treated. So that's the majority of my patients. Then there's another group who will come in and they'll say, Dr. Grimes, just tell me what I have. Well, it's not bothering me now. I just want you to tell me what I have. So it's about patient education. I emphasize to those patients that they should come back at least once a year to get their labs taken, given the comorbid autoimmune diseases that we talked about. Now, there is another population of individuals, Leon, who they do not want to have their vitiligo called a disease. They do embrace it, and they consider it a beautiful difference. And and for those of us who have been in the trenches with vitiligo patients, I'm very respectful of those individuals. My recommendation, however, is yes, you can embrace your depigmentation. However, please recognize that in embracing it, it is immunologically driven. It is associated with comorbid conditions. So please, at least have your labs checked once a year, because we don't want to miss anything. And we want to be, we want to be excellent caregivers. We want to optimize your care and your outcomes. And that is how I engage and embrace those individuals. And I do it with dignity and respect.
That's really good to hear. That's really commendable. I have an interesting question. What about topical bimatoprost 0.3% in combination with mometasone lotion?
Well, we use that. Well,
Okay.
we did the study. it was the FDA would not allow us to use Bimatoprost back in the day on the face. So we had a group with just steroids, we had a group with Bimatoprost, and then we had the combination group. And that combination works great. So as I said, the F2 alpha analogs, the prostaglandin analogs, they do work. There's no question that they work. They don't work as well probably as corticosteroids and the calcineurin inhibitors and the JAK inhibitors, but they do work. And so I have a patient right now who, again, you know, that's been my go-to for him, and he had such an amazing response. He's one of many.
One final question. We are almost getting there. I guess time flies by when you're having fun, huh? It's about third-party payers and coverage of treatment and medications, which is it's a good question. It's a practical issue that we face every day. And I know, Neil, I heard from you that you were lucky you had good insurance, but Pearl, since you see quite a high volume of those patients, do you face challenges, difficulties in coverage?
Sometimes we do. We usually get their general visits covered, but where we struggle, we will still, depending on the company, we may struggle with narrowband phototherapy. Some of the insurance companies still push back and they'll say, this is cosmetic, this is not medically necessary. And we're still struggling with laser coverage, no question about it. And that, you know, they literally will cover the laser or phototherapy for psoriasis, but we get pushback on vitiligo.
And the topicals as well, the insurance does not always cover a good portion.
Yeah. Well, on that note, I'm gonna ask Neil, we're almost there. Neil, do you have anything to add? Did I miss anything to cover in your story?
I could talk about my teenage acne, but I do really believe this. You know, if you give a woman a cosmetic makeover, and there's so many shows, and she looks in the mirror and she feels so much better about herself. The same with these autoimmune skin conditions. If you look in the mirror and you can feel better about yourself, you're in a better mood. And when you feel good, I think good things happen to you because you go out in the world with confidence. And so, again, I got hope, I got a cure, and I feel so much better than when I came into this office for my very first visit. So I think it is important, educate yourself as a patient and find the right physician who will give you the answers to the questions.
Thank you, Neil. Pearl, as last words, we're almost at the top of the hour.
Well, number one, I hope for all the physicians and caregivers who have joined us, number one, you've heard from my patient regarding his journey. He's stable and he's done well. So, as I said, I'm optimistic regarding our path forward. Help us disseminate the knowledge. This is not a cosmetic condition. It is a treatable condition. Let us dispel angst and provide our patients with hope. And in giving them hope, we are enhancing their humanity and their health. And as caregivers, that is our job. And it's certainly my passion.
Thank you so much. First, I'd like to thank you, Neil, very, very much that you come here and you spend the time and share your experience. I think it is so valuable for all of us in dermatology community and to my audience. And Pearl, I thank you so much for your expertise and for your experience in this treatment of this disease that are very, very helpful to us. So this concludes our third series on vitiligo. We started with Dr. Simal Desai, then we had Dr. Firas Ujair, and this was the final treat with Dr. Pearl Grimes. I thank you so much for joining us, and I wish you a good night. Thank you, Roxanne, as well.
Good night, everybody.
Bye-bye.
Bye.